Hello, my name is Dr. Alan Chudzinski. I'm the Director of Colon and Rectal Surgery for AdventHealth Tampa, and I'm Professor of Surgery with the University of Central Florida College of Medicine. Today I'm going to be giving an online discussion on robotic total mesorectal excision. As a disclosure, I'm a proctor for Intuitive Surgical. I was trained as a laparoscopic and open surgeon. I'm not pushing the robotic platform. I think it's great for my particular practice and offers the best benefits to patients. Trying to stay ahead of the curve. I'm here to tell you, you can do it regardless of where you are in your career. Much has been made in advancements of surgery in general for rectal cancer, looking at many historical surgeons who've made great progressions from a transanal approach to a transsacral approach, from the abdominal perineal resection, the low anterior resection, and certainly with the advent of circular staplers in the 70s. Additionally, rectal cancer advances have been made in the form of discussions of the total mesorectal excision, which was discussed by Dr. Heald in 1982, again with sphincter-preserving resections and the role of different adjuvant and neoadjuvant chemotherapies, including FOLFOX and FOLFIRI. The goals with surgical resection of rectal cancer include local control, the prevention of distant metastatic disease, as well as long-term survival. If possible, we'd like to preserve the anal canal and the sphincter complex, and also preserve all urologic and sexual function, and offer the patient a high quality of life. In general, the standards for margins of rectal cancer include 2 centimeters. However, a 1 centimeter margin may be adequate, and that will allow sphincter preservation, and so research has been done with great outcomes showing achieving negative radial margins and circumferential resection margins of 1 millimeters are acceptable, as well as minimal margins with negative gross margins to allow for sphincter preservation. This can all be achieved with a total mesorectal excision, and also what can be referred to as a tumor-specific total mesorectal excision. A total mesorectal excision infers that you're going to take the entire mesorectum of the entire rectum. If you have a high rectal cancer, you may end up doing a total mesorectal excision that is tumor-specific. In other words, there may be 4 centimeters of mesorectum maintained. The TME in general, as first described by Heald, discussed the superior hemorrhoidal artery, which is the inferior mesenteric artery, dissecting into Denalvier's fascia and Waldeier's fascia. These are the anterior and posterior fascial planes that we look for as surgeons. Ligating those inferior mesenteric vessels, want to make sure we do a wide cylindrical resection of the levator muscles, and we want to avoid positive circumferential margins, which can be associated with a very high failure rate. Here's a cartoon showing the mesorectum, and I hope you can see with my pointer here where I'm showing the rectum and the outline here of the mesorectum, kind of from a top-down approach in a female pelvis here. Here's a sagittal view of the sacrum, again delineating that mesorectum posteriorly, which would be this plane here. This plane right here would be Waldeier's fascia, and this plane here anteriorly would be where Denalvier's fascia is. Just again, another view kind of how we would take widely this area in the mesorectum, which obviously carries all the important lymph nodes and vascular structures. This would be a dissection for an abdominal perineal resection where we're incorporating the levator muscles and the sphincter complex. So this is a historic picture of how we used to do abdominal perineal resections, and needing to take all this. You can see my glove through the patient's perineal dissection here. But we really want to get away from this kind of resection for our patients and really push minimally invasive surgery. Why? Because that has shown a shorter length of stays. It has shown significantly less pain. It has shown a lower estimated blood loss, shorter time to GI function and flatus, and improvement in sexual function. So what we really have to think about, there's these arguments that I hear surgeons getting into about robotics is better or laparoscopics is better. But really, robotics is enhanced laparoscopic surgery, in my opinion. It's all minimally invasive surgery. It's just taking the laparoscopic surgery to the next level. The technical benefits of robotic surgery includes elimination of hand tremor, which you might seem as minor, but when you're down there in the pelvis and you're dissecting into these fascial planes, it can be very important. You have improved dexterity with 7 degrees of motion, similar to the actual function of the human wrist. There's the 3-dimensional high definitions that the optics, which are great. You have a very stable camera that you're in control of. You're not relying on another person to control the camera. And in my opinion, excellent ergonomics. There are certainly cons of robotic surgery that you have to be aware of. The length of the surgery can be a little bit longer. Certainly it can be longer than an open surgery occasionally. There's a learning curve. It's been stated that it's easier to teach an open surgeon how to do robotics than to teach a laparoscopic surgeon to do robotics. And that's because you kind of have to untrain some of the things that we've learned in laparoscopic surgery. Not in technique, because it should all be the same, whether it's open, laparoscopic, or robotic. You have to maintain a good circumferential dissection, and nothing should be compromised by going minimally invasive. But how you hold your hands or how you expect the instruments to be used can be different. There's the availability of the robot. It can be a hot topic and a hot commodity, and it can be challenging accessing it and getting good times for that. A special team needs to be trained in order to do robotic surgery. You can't just take a scrub tech and a circulating nurse and throw them in a room who've never done robotics. They need specialty training with that. There's obviously the cost of the robotics equipment itself. However, all of these things pay off, in my opinion, when it comes to decreased length of stay, patient satisfaction, and ease of the surgery for the surgeon itself. Robotic surgery is not autonomous. Many people, when we talk about robotics, think we're hooking a robot up and we're walking away. You don't get C-3PO or Arnold Schwarzenegger in there as the Terminator doing it. It's an extension of laparoscopic surgery, and in my opinion, it's the future of minimally invasive surgery, and this will continue to expand. So Arnold is not going to be there holding the patient's rectum back and doing the dissection. Minimally invasive surgery in terms of colon and rectal surgery, current trends, this just kind of justifies some of the things that we're seeing. 50% of colorectal surgery is still being done open in the United States, and conversion rates for laparoscopic surgery can be quite high. And we're seeing these trends decrease when it comes to robotic surgery, and actually the increase of robotic surgery and the decrease of laparoscopic surgery. This is a picture of the robot draped on a patient in use, just for people who may not be familiar with it. It's draped to be sterile, and this is a picture of the robot at rest. Has 4 arms. One of the arms is to hold the camera, and the other 3 arms act to move surgical instruments around. This is the console where, in this case, a fellow on one side and the surgeon on the other are able to operate and use those robotic arms. And in this situation, the patient is immediately behind us, and we're all in the operating room. Clinical reasons for robotic surgery. These are some of the highlights that I think are important. Smaller incision, significantly less pain, significantly less blood loss, shorter hospital stay, significantly less morbidity, and a quicker return to normal function. These are some pictures here of the robotic surgery. These are not permanent ostomies on these patients. This is a patient for a total proctocolectomy with J-pouch, so we temporarily divert the small intestines as the J-pouch is healing. But you can see this very small incisions that are made. This is actually just from the varus needle up top here. But you can see the healing over here on the right side of the screen with the specimen was removed, with all very small incisions with very quick recovery. Again, just some other pictures of patients who have undergone a low anterior resection. Here, actually, this is a J-pouch patient here on the right, and on the left, a total abdominal colectomy with rectal anastomosis. This can also be done in bigger patients. Again, this is a temporary ostomy. This is a low anterior resection, very low with a temporary diverting ileostomy. and we can successfully do these on these patients. These are pictures of the mesorectum, and it's so important, and we'll get into it a little bit later, about some debate going on with the mesorectum and how it's dissected. But these are mesorectal specimens from a robotic low anterior resection. It's been reviewed and graded by our pathologists, and we'll discuss more of that in a moment. So this is kind of an example of how we do it in our operating room. We have an attending, we have a fellow, we have a scrub, you can see our nurse anesthetist and our circulating nurse down here, and our setup in terms of how we might use things in terms of port placement, and we have kind of a delineated area of how we place our ports. This is set up for a low anterior section with a 12 millimeter trocar here, 8 millimeter in the supraumbilical region, and 8 millimeter here kind of in the left subcostal, and in the left lateral region another 8 millimeter. We use 1 or 2 trocars for assist ports. This is a 5 millimeter for this particular patient, a little bit bigger with a challenging dissection down below, and then an air seal device, 8 millimeter. I stress team approach because it's not just the team in the operating room, it's the team on the floor, the nurses who help take care of the patients, the mid-level providers who help take care of the patients preoperatively and postoperatively. And everyone needs to be educated and on board with the robotics approach and our expectations of patients and how they're going to be prepared preoperatively when it comes to enhanced recovery protocols, both before and after surgery, our expectations for ambulation, pain control, etc. This is another example of my port placement that I discussed earlier with the actual photo. Here's a cartoon now, just delineating those port sites for, this is for an XI robotic low anterior section. This is an example of how the room may be set up with a scrub tech, a bedside surgeon, or assist is very important. The robot comes here in the left lower quadrant, the dual consoles in the back, and the anesthesiologist at the top. Everyone has an important role. The tech should not assist, and the assistant should not be doing the tech's job with the instrumentation. The assistant really should not be exchanging the instruments. The tech is the one who should be helping out with that. At the beginning of the year, oftentimes the fellow will start assisting, then progress to the console, and you'll need a first assist once that process has taken place. Here's us docking the robot with my fellow. Docking should not take long. It requires a knowledgeable team and practice, and you do not need to redock in the XI from LAR, which is vastly important. So, laparoscopic versus open colectomy for adenocarcinoma, the end results of studies showed that there was the same specimen with the same outcome. So, lap versus open colectomy for adenocarcinoma, same results. When they looked at laparoscopic versus open for a proctectomy, so like an LAR for rectal adenocarcinoma, it failed a non-inferiority trial due to the quality of the mesorectal specimen. In 2013 was this study. But long-term outcomes so far have been the same. And actually, the robotic surgery is showing a far better quality specimen. So for laparoscopic total mesorectal excision for rectal cancer, there's some conflicting evidence. And currently there's conflicting evidence for the role of laparoscopic total mesorectal excision for rectal cancer patients. The evidence from recent well-executed randomly controlled trials would suggest that actually short-term oncologic outcomes of laparoscopic TME have failed to reach non-inferiority. That's why it was this non-inferiority study. The long-term survival data from limited literature is actually very promising, and it shows equivalence between the two groups. However, of course, more evidence is needed from more recent trials, which need to be published to further evaluate this. But I have great hope because when it comes to robotic mesorectal excision, things look very promising for that. So it's my belief that in experienced hands, robotic rectal resection is not inferior, but is equivalent to an open resection. In saying this, it's important that whatever modality the surgeon chooses, the surgeon has to be comfortable and well-trained in their particular technique. Ultimately, the quality of the surgery will facilitate the outcomes for the patients and hopefully the desired long-term outcome of longevity and cure of cancer is obviously what we're going for. So again, a different specimen here, just showing, this is also from a robotic proctectomy, showing a very much intact mesorectal excision, which is justified not just by my own self saying that, but by our pathologist who created this specimen. Robotic surgery compared to conventional open. Why are patients feeling better? Why do we think they do better with minimally invasive surgery? These are studies that looked at stress levels, looked at HLAs, looked at inflammatory markers like IL-6, and preserved immune function. And all this has shown that these stress levels and these inflammatory markers are significantly decreased. More recently, endocrine and metabolic markers have been studied in an attempt to qualify the operative stress that a patient may undergo. HLAs and IL-6 have been proposed as potential surrogates to measure surgical stress response, and the evidence suggests that there's actually a preserved immune function and less inflammation in laparoscopic and minimally invasive surgery compared to open conventional surgery. This is a little video, which I hope you'll be able to see online okay. Starting the dissection here of a portion of the mesorectum. You can see the ureter, which is actively moving here on the right, but also the ureter here on the left. The green that you see is the ureter lighting up under the fly technique with using ICG, and we're beginning the mesorectal dissection here, kind of demarcating the anterior border where we'll start getting into Denalvier's fascia. By the way, this is a 53-year-old woman presented with rectal bleeding. An MRI showed a 2.5 centimeter mass in the left posterior lateral wall of the distal rectum. She was staged as a T3A-N1. She received neoadjuvant chemotherapy and radiation and was scheduled for an abdominal perineal resection, as this did involve her sphincter complex. You can see the dissections being done here. And this video does not really give justification to the three-dimensional aspect here. Lifting up here posteriorly, we've gotten into Waldeyer's fascia. Here we're going anterior again and starting to get into Denalvier's fascia here. The lateral stalks have been taken down here on the left. As you see here, we're extending that down posteriorly. And this is that beautiful Waldeyer's fascia that you really want to see here. Our dissection is continuing further down here, and we're taking off that mesorectal plane anteriorly. There's an EA sizer that was moving around there in the vagina. Sometimes the radiation can cause a significant amount of inflammation. You obviously want to avoid injury to the vagina and surrounding structures, thus are placing the sizer there. And we're just moving around circumferentially. This dissection continues on and on circumferentially until you're at the levators. And then even robotically, you can, for an abdominal perineal resection, dissect deep down into that levator and into the sphincter complex, making the perineal dissection less and less and easier for the resection to be undertaken. We're just finishing up some of our anterior dissection here. As we move further down, you can see here, this is the number one arm that's offering a little bit of a retraction anteriorly. And this is a monopolar device in my right robotic arm that I'm using, and a fenestrated bipolar grasper in my left. That again, constant manipulation and retraction of the tissue is being undertaken in a safe and gentle fashion in order to be able to visualize. The assist has a suction. The smoke evacuation is very important. We're in a small space here in the pelvis, and the smoke builds up very quickly and can allow decreased visualization. Can also obviously help with some bleeding. And we're just moving around here circumferentially, allowing that dissection to occur in a bloodless plane, essentially. Can be challenging due to some fibrosis that can occur, especially at the site of the tumor where it's been radiated. So this is just looking at some of the studies that have been done, just to kind of show some proof of what I've been discussing, the effects of robotic surgery and how it can still be quite effective in what we do and how it can offer significant benefits to our patients. This was results of a study that was done between 2011 and 2014, essentially showing no significance was found between the groups of intraoperative complications or postoperative complications when it came to robotic and open procedures. This is comparing robotic versus laparoscopic surgery in over 7,000 patients, again showing negative resection margins to be excellent, conversions to open being less with robotic surgery, and 30-day readmission being very good and actually less than laparoscopic. Again, another systemic review. This one do a meta-analysis comparing minimally invasive techniques for rectal cancer in terms of the quality of the mesorectum and the surgical outcomes. And again, showing some great results demonstrating that the techniques are comparable across TME quality. This was looking at meta-analysis at 739 publications. This is a comparison of open laparoscopic and robotic colectomies that were undertaken at high volume centers from 2009 to 2012. Again, showing minimally invasive surgery still being performed at high volume centers and being done very safely, and that robotic colectomies have actually increased significantly over a period of time as robotics have become more standardized and more popular in a sense. Just some more studies kind of validating what we're seeing in our own practice. So the end result of this is patients do very well, and we're very pleased with the outcomes for robotic surgery, and we think there's excellent justification. Here's a happy patient that surprised us with these socks that she put on post-op day 1, still rolling, no colon. So patients actually look for this, look for centers to do robotic surgery, and with the correct learning curve, with the correct training, patients can have excellent outcomes with robotic surgery, can have excellent outcomes for their robotic rectal cancer resections with very little morbidity, very little mortality, greater return to normal life function at a greater rate. I thank you very much for your time, and I wish you all a blessed day. Take care.